Hello, everyone, and welcome to this virtual chapter panel session entitled Executive Leadership During COVID-19, presented by San Diego Organization of Healthcare Leaders. I am Craig Thompson, your session host representing the National Office of ACHE, and I speak for everyone when I say we are glad you're here. Before we get started, I would like to go over a few items to help you navigate the program in our virtual environment. For the purposes of noise control, your lines will be muted for the duration of the session. We welcome and encourage you, though, to submit questions through the chat function at any time during the event. You can also use the chat to share resources or comments regarding our topic with the rest of the participants. If you are on the go during the session, please participate using the Zoom app. And to help ensure you receive your learning credits, please make sure the name that is showing for you during this Zoom session matches the name with which you registered for this event. Today's session is worth 1.5 hours of ACHE face-to-face education credit. Credit will be applied to your ACHE account approximately 2 weeks following the end of the session based on your attendance during the entire session and completion of the evaluation. This session is being recorded and will be available within 48 hours by navigating to your My ACHE account on ache.org and selecting My Online Learning from the Helpful Links section on the right side of the screen. Now, to begin the session, I am happy to turn it over to an annual program co-chair for San Diego Organization of Healthcare Leaders, Peter Chu. Peter?
Hi, Craig, and good afternoon, everyone. Thank you for joining us for the 2020 Annual Conference Program Kickoff on behalf of the San Diego Organization of Healthcare Leaders. Welcome. So on behalf of the SOHL Board, Annual Conference Planning Committee, and my annual conference co-chair, Johan Otter, welcome to the first of 3 panels composing SOHL's 2020 Annual Conference, revamped and restyled this year as a multi-day virtual series. We will now provide a brief overview of SOHL before introducing our speakers and moving into today's content. So to provide a quick snapshot of our chapter at a glance, when you join ACHE, you automatically become a member of the San Diego Organization of Healthcare Leaders by residing in this region. SOHL is your local connection to ACHE and seeks to provide you with learning, networking, and volunteer leadership opportunities, including programs like this that qualify for ACHE education credits. We are also home to over 500 members with various professional and personal backgrounds, experiences, and perspectives. As you can see, our membership status is quite varied, from anywhere from chief executive officers on this session today to students who are in graduate school advancing their healthcare management careers. And we also represent organizations across the spectrum and across the region, from hospitals and health systems, including academic medical centers and community hospitals, to not-for-profits and more. Our goal as a chapter is to enrich your professional development and add value to your membership by providing networking opportunities, facilitating mentor-protege relationships, offering opportunities to volunteer on our board, as well as different committees, planning thought-provoking educational programs like the annual conference for members of all levels, as well as assisting with advancement to ACHE Fellow. And whether you are just beginning your career, in transition, or on the path to earning your FACHE credential, you can take advantage of the career management tools and resources offered through ACHE and SOHL to help advance to the next level. Promoting your FACHE credential signals your commitment to the healthcare profession and encourages your colleagues to follow you on this journey to become a recognized leader in healthcare management. Choosing to become credentialed in healthcare management enables a professional to demonstrate his or her competence, leadership, and commitment to the profession. It also provides evidence of that individual's commitment to lifelong learning, management excellence, distinguishing oneself in the field, and ethical conduct. We also offer various other programs and events throughout the year in addition to the annual conference, including our annual membership appreciation event at the beginning of the year, CEO rounds, leadership pearls, tours of facilities in various counties, our executive leadership program, and more. And of course, SOHL's operations would not be possible without the dedication and commitment of our volunteer board of directors listed here. This team, composed of representatives across Southern California, put in thousands of hours every year to organize programs that encourage professional development and growth. And then in 2020, SOHL was fortunate to have the support and commitment of 13 sponsors listed up here on the slide. Thank you so much to each of these organizations for supporting us this year. And finally, please do engage with the chapter through our various social media channels, Instagram, Twitter, as well as our Facebook page and LinkedIn page. And if you have any questions, including about how to join or about the FACHE credential or more, please reach out at info@sohl.achechapter.org. Did want to note that SOHL is also a recognized Live Well San Diego partner. In 2010, the Health and Human Services Agency and the rest of county government embarked on its boldest and most ambitious countywide social movement known as Live Well San Diego. This groundbreaking, data-driven strategy is a high-level collective impact for population health and social well-being improvement. Live Well San Diego is being implemented countywide through hundreds of public-private partnerships in building better health, safer living, and economic vitality for all San Diegans. Now, for those of you who joined us in October of 2019, the month when our conference is typically held in person in a large and bustling room filled with food and chatter, you may remember that that annual conference focused on emergencies in healthcare. Many of our discussions then seem incredibly prescient now. This year, SOHL's 12th annual conference will gather speakers ranging from senior leaders of multi-hospital systems and federally qualified health centers to frontline nurses and lab technicians. Our aim is to generate discussions that capture the Southern California experience with the global pandemic, what we have learned so far, and how we as healthcare professionals should proceed when planning for the future. It takes a dedicated community and intense local collaboration to provide access to consistent, high quality, and affordable care. And we want our annual conference this year to highlight our strides, progress, and continued work ahead, not only in San Diego, but also neighboring Imperial County. Without further ado, it is my honor to introduce the moderator for today's panel, Nick Macchione. Nick is Director and Deputy Chief Administrative Officer of San Diego County's Health and Human Services Agency. He directs a workforce of 6,200 employees with an annual operating budget of over $2 billion that supports all 3 million plus residents of the county. Nick oversees the delivery of safety net programs, including emergency medical services and disaster response, behavioral health, Medicaid managed care, nutrition assistance, child welfare, support services for active duty military veterans and their families, and much more. He is also a fellow of the American College of Healthcare Executives and has previously served a 3-year term as the elected regent for San Diego and Imperial counties. Nick holds dual master's degrees from Columbia University and New York University, specializing in health services management and health policy. He has also earned a senior healthcare leadership certificate from Harvard University. And for over 2 years, he has been an instructor and faculty member at SDSU's Graduate School of Public Health and holds the endowed position of the John Hanlon Executive Scholar for the Division of Health Management and Policy. Welcome, Nick.
Thank you, Peter, and good afternoon. Thank you, everyone, for joining us this important session. Let me first acknowledge the volunteer board for SOHL. Remarkable individuals in their own right, whose sole mission is to help build the healthcare leaders of today and tomorrow. And this session is just all about that. It's building and improving all of our leadership skills, whether an early careerist student or a senior careerist or in between. So to the entire board, thank you. Also to Craig Thompson, and perhaps the best professional association in the country with the American College of Healthcare Executives. Thank you for joining us, and thank you for all that ACHE does for our local chapters and our whole profession of healthcare leadership. As Peter mentioned, this is the first panel of the executive leadership during COVID-19 that is being presented by SOHL. And today's panel will feature healthcare leaders, which I'll introduce in a moment, from Southern California, as part of a broad discussion of how different organizations have dealt, are continuing to deal with, and are planning still yet in the near future with the great uncertainties and demands of COVID-19 for our workforce, for our patients, for our entire communities. This includes discussions around testing and triaging and innovative treatments of severe cases and consideration for yet continued growth of the pandemic in Southern California and the nation throughout. As Peter mentioned, my name is Nick Macchione, and I have the honor of serving as a moderator and as much as you in the audience and hearing from our esteemed panel. But let me just add that in my role, we all have, every one of us, have taken on additional responsibilities we've had to during times of crisis. And I am talking to you from our county emergency center, our COVID emergency center. And then back in late April, no such thing as sabbatical, but took on an additional assignment, moved from AC director to moving into and standing up what we call T3, our testing, tracing, and treating strategy for our region, moving from expanding our testing with our great hospital partner labs, our county lab, commercial labs, doing perhaps the most innovative work in the state and expansive work with all candor around COVID-19 PCR testing and beyond. In addition, more recently, in the last 2 months, I've been leading the work for our seasonal flu and COVID-19 vaccination efforts. Again, working with our hospital partners and many, many others throughout our county of preparing with urgency of how we roll out the vaccine. And I know that'll be part of our discussion today. And lastly, the county as an institution, look, our motto is the noblest motive is the public good. And so we have amazing people working here. Our public health officer, Dr. Wilma Wooten for San Diego County, tireless advocate, and many around her of our county teams and many other partners, many of you working together to fighting the pandemic. Peter mentioned Live Well San Diego. The best antidote to a pandemic is population health, period. And that requires the ecosystem of our hospitals really being the lifeblood of saving lives, but also the leadership that comes with that in our clinics and our nonprofit organizations and first responders and the many sectors that go around in that ecosystem. And today we're going to be talking about our hospital leadership and ambulatory care and outpatient care. But know that it requires multiple sectors in this work, and indeed, many of these leaders you're going to hear from are working with multiple sectors, even beyond their own institutions, as we have to, because the best antidote to a pandemic is population health leadership. So with that, let's jump into this. We have a great panel. We have, and I'll introduce them each as they go up, but first, let me, as you can see on your screen, we have Chris Van Gorder, President and CEO of Scripps Health. A good friend and colleague I've known for 23 years. He just keeps looking better each time in his pictures, and I don't. So I'm envious of that, of Chris. But on a very important note, he has served as both a governor and the board chairman for ACHE and has represented our region exceptionally well with ACHE and SOHL. And I'll talk more about Chris in a moment. Dr. Adolf Edward, who is the CEO for El Centro Regional Medical Center, doing remarkable work in Imperial County. And he'll be sharing some real great innovations, and I'll introduce him further. And then my good friend down in the South, in South Bay, National City and Paradise Valley Hospital, Nirav Yajaja, who is the CEO of Paradise Valley Hospital. Remarkable individuals who will be sharing more. So we're going to go start with Chris. We'll go Dr. Edward. We'll go to then Nirav, where Peter is going to help looking for a chat. Please do present your questions. We're going to take the questions after our panelists have made some introductory remarks. I will, as moderator, have a few questions I'm going to present to them, and then we're going to get to your questions on the panel. So we encourage this to really be the conversation with you, and we'll have ample time for that. So let me start with our first presenter, Chris Van Gorder, as I mentioned, who I've known a long time. We are going to give the bios for each of our 3 panelists that will be presented on the SOHL website and sent to you. Because honestly, every one of these speakers, and starting with Chris and the turnaround he's done with Scripps Health, could be its own presentation, which he has done. But as a snippet, let me just mention that Chris has been the driving force in making Scripps Health what it is today, the nation's foremost healthcare institution in its ranking, its reputation. But more importantly, he'll talk about his workforce and the patients' lives that they make a difference in. Chris oversees all functions of a very robust integrated health system. If you're not familiar with Scripps Health, it's 5 acute care hospital campuses, dozens of outpatient centers, a very cutting edge Previs Cardiovascular Institute, as well as the Scripps Anderson Cancer Center, and the list goes on. And as I mentioned, has served in many roles, including as our governor and past board chairman for ACHE. So with that, Chris, I'll turn it to you.
Thank you, Nick, and I appreciate that very much. And first of all, let me tell you how proud I am to serve with this really august leadership panel today. And I'm proud to be associated with them literally on a day-to-day basis in helping manage this pandemic in our community. And Nick, for your leadership, the county, I can't thank you enough. It's been extraordinarily challenging for all of us, but some of us don't face the political pressures that you also have to face, in addition to trying to keep safe an entire community and county. And for all of you participating, I've been a member of ACHE for more than 40 years. I hate to even admit that now. By the way, those photographs were taken at a better day. We're all looking a little bit more beat up today after these months in the COVID pandemic. But I really appreciate you tuning in today for being a member of the college, a college that I'm extraordinarily proud of. It is a premier professional association. And if you get a fraction of what I've received by being a member of the college over the years, it will be well worth it. I promise you that. And thank you for supporting our local chapter as well. Let's just get right into it. I have a few slides that kind of just introduces the topic today. We'll go to the next slide. I'm not going to spend a lot of time talking about Scripps per se, but I'll tell you there's one thing that I'm as concerned with as all of my colleagues, and that's the 20,000 people I'm responsible for, and trying to make sure that they stay safe during this pandemic, have the appropriate equipment and personal protective equipment, supplies, and all those things so that they can actually put hands on patients and serve this community. And I see that as a very, very significant responsibility. And I know there's some members of my team on this call today and some folks that used to work with us, and it's good to see you. And luckily, I have been successful over the years because I've surrounded myself with nothing but the best. And they frankly make me look good every day. Next slide. We've been in this pandemic now for some time, and go ahead, go to the next one. This is my command staff. So it really for us started in January. Like everybody, I think we were watching what was going on in Wuhan, China. And as we saw it start to spread from China into Europe and others, there was no doubt in my mind that COVID-19, it wasn't named that at the time, but the coronavirus was ultimately going to make it to the United States. And this had a possibility of being really a very significant medical issue for our country. I pulled our community, our Scripps community together first in January 27th and started establishing what may have been the most important thing to do, which is open lines of communication with all of our physicians, with all of our employees on a very, very frequent basis, literally on a daily basis, and with members of the community. I reached out early on, obviously, to the county, but I also reached out to the local FBI because they had access to intelligence information that was available to the general public, but many people wouldn't know where to go to. The Department of Homeland Security, because we are a border community, to Customs and Border Protection, because there's all sorts of information and intelligence that I've been able to gather from them that's open to the public, but most people don't get it, to help us plan and prepare for what we have seen since that time. By February, we knew that there were Americans coming to Miramar. We knew that they would have to be cared for in our hospitals if ill. And actually the first patients went to UCSD as inpatients, and the first ambulatory patients we took care of at Scripps Mercy Hospital. We activated our command center, our system-wide command center here, which is right around the corner from me. And it's still, this is, by the way, day 292 days of operation today. since we opened up our command center, and I suspect it's going to be open, sadly, for more than a year. And we continually staff that. And then we activated all of our site command centers so that we could be tightly connected from a communication and a need standpoint. Interesting, back in February, I actually had doctors calling me saying, my God, we ought to be lending and sending PPE to China because they were in great need for it. And I'll never forget saying absolutely unequivocally no. This is going to be the hottest item in the world in just a matter of weeks, if not months. And I said, in fact, I want to put everything we have under lock and key because we're going to have to protect that. And that turned out to be a good decision on our part. We implemented visitor restrictions, as everybody did, probably around March, and we received our very first COVID patient on March 10th. Fortunately, we've been following what the county was doing. Obviously, they had COVID testing first, but our team at the lab, and there's just a lot of people that have literally been heroes between our pharmacy and our lab and our supply chain and all these people in support of those that put hands on patients, and nobody's more heroic than our frontline staff members, doctors and nurses and others. But we received our first COVID patient on the 19th, and we had COVID testing available just a couple of days later. That helped take some of the pressure off the county, and of course, all the hospitals have subsequently put in testing capability. March 14th, we received some more patients from Myanmar, and then by May, obviously, we were deep into this as we obviously had cut our quote-unquote elective procedures way back, opened up 50% of our capacity, did that for a number of months. We had to go through all sorts of issues, obviously, with our employees telecommuting. I have over 3,500 employees that are still telecommuting today. We've done more than 285,000 telemedicine visits. We'd only done a handful prior to the COVID incident. So, a lot of things became, changed in our organization. Next slide. So this gives you just a visual snapshot of our command center. Dr. Ghazala Sharif, she's our chief medical officer on the acute side, and she and I are the co-incident commanders since the beginning of this incident. And of course, what we've all done is establish outside testing in cabanas or tents or other things to, prevent COVID from getting inside the hospital if it was possible to do so. I mentioned already the early visitor restrictions, which was really for their good, but also to preserve PPE. We got on supplies immediately, and I had doctors wanting to double our supplies of ventilators. Of course, by the time they wanted to do that, they weren't available at all, but we went ahead and ordered vents, PAPRs, personal air protective respirators, and a variety of things that we were able to get in within a couple of months. And so they were all very useful. And then, as I said, established our key connections with the state, the county, and federal agencies, and then really started what we call our stage response. We're very experienced in disaster management with our medical response team. We were in Haiti, we were at Katrina, we've been in a lot of organizations or countries and disasters. So we were pretty well prepared for this, as if anybody could be prepared for a worldwide pandemic. And so phase one was our planning and mitigation. Phase two is the San Diego community transmission, which we all hoped was not going to go to community spread, but ultimately did. And phase three, of course, is disruption of services that we had to manage. Next slide. So the early things we did, we established, for example, a nurse call. And at one point, we had more than 60 nurses that were taking calls from all over the community, from all sorts of different, we had Kaiser patients calling us and Sharp patients, Scripps patients, Palomar patients, because we had a call center and there was so much anxiety and fear. We were able to direct them to the right things to do and the right places to go to if they needed help. And of course, 211 is another big asset to the community for that as well. We started communicating with our staff members literally every day, and we literally put out what our supply of PPEs and supplies were, where we were short, all of the issues, so we were transparent with the organization. And subsequent to that, we have heard from our staff members that they really appreciated that transparency. And in fact, this year when we did our employee engagement survey, we actually went up 5 points right in the middle of COVID, which I think really relates to the way we communicated and everything we did to try to protect our staff members. Did in-house data analytics. I'll show you a piece of that. I mentioned the nurse triage line, our car testing, and again, our collaboration with the community. Next page. So this was we got our data scientists to create predictive analytics as to the numbers we were likely to see in our hospitals and within our community. And that's been extraordinarily helpful when it comes to planning, supply acquisitions, and a variety of things like that. And so this is just a snapshot of what we call the President's Dashboard, which is available to all employees to be able to visualize and see and dive actually into the detail so they can understand what's going on behind the scenes. I've always believed it's the why that's important. We tell people a lot about what we're doing, but why we're doing it is the critical aspect. And we wanted people to be able to get all that why information they possibly could. Next slide. And our response, regional, as I mentioned already, we reached out to all of the agencies that could provide information to us and that we could supply information and intelligence information to them. Even reached out at one point to the Chief Medical Officer of Homeland Security, who actually came to town at the request of the county and had a meeting with the chief executives. And I think that was very helpful, particularly for Imperial County, because it was just the week after that, they started pulling resources for our colleagues out in Imperial County. And then a lot of alignment within our community. I sent a memo at one point, I think, to Nick, and Nick called a meeting with the Hospital Association the very next day, used some of the items I'd put in that memo as the agenda. And from that point on, we started meeting every week. And shortly thereafter, the chief medical officers actually got together and they started meeting every week, really collaborating together, trying to standardize and make consistent political decisions, community healthcare decisions, and clinical decisions that could be standardized across all of our healthcare systems. And I think that was just unprecedented collaboration. I've never seen anything like it before. And I can tell you there's communities to this day outside of San Diego that are jealous of what we have. And so again, I want to thank my colleagues for that. The collaboration has just been unbelievable. And we were proud to be a little bit of a lifeboat for my colleagues in Imperial County. I think since the pandemic began, we've accepted about 326 patients from Imperial County. And at one point, I know that was absolutely critical to them while they built up their capability and got additional support. And they're holding their own right now. And I'm very proud of my colleagues out in Imperial County. Next page. So where are we now? Now it's, you know, we've been in this a long time and people are getting tired. And we're actually seeing some of the spread in our community comes from pandemic fatigue. And that's happening even within our own healthcare organizations. And when we had our last surge, and at that point, Scripps got its maximum number of patients, I think was about 129. Today we're at 175. And back then we could get registry to help us. We could get travelers to help us. Well, now it's no longer a regional pandemic, it's a national pandemic, and those resources aren't available. And on top of all of that, we have our own employees who are getting sick now. And so we have fewer employees of our own, and yet we can't get those outside resources. So right now, it's managing fear, it's managing anxiety and exhaustion. We have put in peer-to-peer support programs and a lot of support programs for our employees, but we're about ready, I think, to see a much more significant spike. I don't know if this is the Halloween spike, but we certainly haven't seen the Thanksgiving spike yet, or the Christmas spike, or the New Year spike. And already our hospitals are being taxed primarily from the staff perspective. We've got beds, but the question is going to be, do we have enough staff for those? And we can get that into the discussion. We did return back to almost full service, but now we're doing what I call the teeter-totter approach. As COVID builds up, we're cutting back on those more optional cases or cases that could be delayed a little bit. Obviously, we continue with the emergency cases, but there are a few cases that could be delayed for a while, even cases that might end up in the intensive care unit to open up that capability to manage the COVID. And so right now we're in the beginning of what I call this teeter-totter approach to managing our volume. And that's where we are. We have a vaccine around the corner. Literally, I hear that we may actually have some delivered to this county by the end of this week or this weekend. We have no idea what that quantity will be, and it'll be some time before, obviously, vaccines save the day. In fact, we may be through most of next year before that happens. So right now, what it comes down to is protecting our hospital capacity, serving our community the best way we can, trying to protect our staff members while we're doing that, and then working together to move resources around our community as they're needed. And that the county will help us with, and of course, all of my colleagues and I will work together to try to do that. And go to the next slide. And I think that's it for me on mine. And so we do have a vaccine committee. I know the county has a vaccine committee, the state has a vaccine committee, the feds have a vaccine committee, And we're all studying the vaccine so that we can be voices of knowledge to our doctors and our staff members and our patients when the time comes for that vaccine to be distributed. And with that, Nick, I will turn the time back over to you. Oh, by the way, let me just show you one slide. I was going to do it anyway. This is where we are right now, folks. I'm not sure I see that there. That was the early spike in the summer. This is where we are now. And so right now there's over 700 patients in the hospitals, and my colleagues at Sharp have 277 today. And we have 175, and this is real. So with that, Nick.
Thank you, Chris. And, you know, we appreciate you, appreciate your self-leadership that you're doing for our entire county. You know, the chart Chris just showed, by the way, we are pretty close to doubling where we were at the peak almost in July, to put it in perspective. And it'll be talked about and we'll talk about this issue about what we're seeing in our hospitals, but the throughput of our patients. So Chris talked quite a bit about burnout with our heroes of our clinicians, but the demands on our clinicians and nurses and doctors and therapists and so forth. We pray for their health, and they're getting sick, as Chris mentioned. So lot that we have to manage, and just remarkable what you shared of what you've been managing, and yet still what we still have to do and are doing together. So thank you. Next up is Dr. Adolf Edward. As I mentioned, Dr. Edward is the CEO for El Centro Regional Medical Center, an acute care medical center in Southern California's Imperial Valley that's affiliated actually with UC San Diego Healthcare Network. Dr. Edward brings to the position more than 30 years of experience in healthcare strategy and operations at public and private systems, both nationally and internationally as well. And I know in talking with him, he's doing some really innovative work in his medical center serving all of Imperial County. So very delighted to have Dr. Edward.
Thank you, Nick, so much. And thank you, Chris, for the opening remarks. I want to start by a person that I really respect a lot. Secretary Colin Powell said it best, says that the leadership is the art to accomplish more than the science of management says that we're capable of doing. And during a pandemic, during a national outbreak like this, we need all the leaders. I want to thank the team here at ECRMC because each and every one of them have stepped up and taken over a leadership role to try to help us get through. And we were hit really hard. The focus on the US at the time when we started this was actually, when will we reach the peak? And unfortunately for all of us, and we need to recognize that that was the wrong focus, because by the time you're at a peak, you're actually starting to go down. So it's too late for your strategy to get up and to what you need it to be. So you got to be very careful. You don't want to have a misguided strategy leading the way for something that you're too late to respond to. Early starts are really good. I want to go back to the timeline that Chris was showing. For us, it was a little bit different. On the 18th of February, the CNO, and I have the best CNO in the world, Lou Kenny, and I met, and she looked at me and she goes, well, it's time for us to open the command center. Thanks to 23 years in the Air Force, I knew exactly what we needed to do. And Chris, I see that Air Force hat right behind you. I'm glad that you're showing it. What a proud moment for me to see that hat. On the 8th of March, I announced on social media our first COVID positive patients. And at one point during the COVID 1.0, the first cycle, we were at 62 patients. We went up to 65, and I had to call the state and say, we're going to need a lot of help down here. We're sitting right now, as of yesterday, at 62 patients already. So COVID 2.0 is starting to be much higher. As Chris has said, we probably have not seen yet what Thanksgiving is going to give for us, but it's going to be, by the end of this week, a gift of about 75 patients in our hospital alone. Across the street from us, the other hospital that we have, PMH, we'll probably have about 30 patients. That's a lot of patients down here for the Valley. It's incredible. But morning huddles help. But I want to start also by thinking about the death toll. We're not talking about the mistakes we've made in public health. We are going to live with that death toll for a long time. It's a crying shame on us not to respond and respond well. So we've got to be thinking about what is the leadership requirements that's going to get us through this. How ready are we all to get through this next wave? Because we don't know how long we're going to live with this. It's going to eventually go from a pandemic to an endemic where we're going to have to live with it for a prolonged period of time. The other thing that I want to maybe share with you is that, you know, civil unrest gets to be a part of outbreaks. So we need to understand what kind of leadership do we need in our facilities to work in a kind of not just the civil unrest, but this fact of COVID fatigue, because not only is COVID fatigue affecting us and our staff, but COVID fatigue is affecting our community. And how do we build towards that? And then how do we expect the unexpected? Because while we thought that we had all the N95s we needed, I was so glad that my CNO was smart enough to say, you know what, we're going to fit test all of our staff for all the different types of N95s. And it took a team of a lot of people to actually stand behind us to be able to do this. Now I'm comfortable because we've got enough N95s to get us through the day. Some would say, well, your surgical mask is enough. And some people don't believe that. So we have to provide what we need to provide for the staff to make us believe in what we're doing. I think one of the traits that I'd ask everybody here to have is, as you see, remaining calm during something that we don't know is really an art that we should all perfect so that we can get through the day. If you start to try to go too fast, you're not gonna do right. So go slow to go fast is another leadership trait that we have all learned. Mental health is gonna be a big issue. There's no need for us to kind of talk about it, but honestly speaking, at this stage, my staff, as well as everybody here on this call and everybody speaking staff is really beyond COVID fatigue. So what do? We've had actually, thanks to our lead in quality, Nicole Amadon, put together some of these great things of employee assistance programs, spiritual services, behavioral health crisis hotline, national suicide hotline. We passed it out to the staff and it was a great thing because it helps you mentally, but we can't Lamaze our way through another 9 months of this. So what are we going to be doing to actually get us through it? Also, I want to change our perspective a little bit. We talk about PPE as personal protective equipment, but it's actually PPE is politics, pandemics, and the economics. The politics of this pandemic has been really strange. And everybody, and I'm not going to talk about the politics at the highest level. I'm going to talk about the CARES Act, for example. The dollars that we got from the CARES Act, frankly speaking, because of the losses, are dried up for our facility. So, and I'm glad that the California Hospital Association, the American Hospital Association, people like Chris that occupy a very powerful position in the healthcare system is really pushing for us to get through the day and get through our elected officials to make them understand that this is something that we need to have support. Financial support is going to have us avoid the 1 in 4 hospitals in California that are running in the red. I actually wake up in the middle of the night worrying about where we're going with our finances. I'm a very small budget, very small margins, and actually have been running about a $2 million loss a month. So I can't sustain that for a prolonged period of time. Also, leadership vacuum. Again, I'm not going to discuss about leadership vacuum at the highest level, but within your organization, avoid leadership vacuum, because what you have then is you open the doors up for confusion, chaos, and a loss of momentum. And you don't want that to happen. So as a part of the leadership, we've got to drive actually to think about how we do that. And remember, I love, Nick, what you started us with is public health is life savings. You know, universal measures like uses of a mask shouldn't be a political issue, but yet we know that it became a political issue. Dr. Tom Friedman talked about the model of test, isolate, treat, and quarantine model. And unfortunately, because we had not a colossal failure, if there's anything worse than that, the contact tracing was not fast enough for us here in Imperial County. It took us a while to ask for federal help or state help. We should have actually prepared early. We should have asked for more. Testing right now, and I'm going to remind everybody that with Cal OSHA letter that just came out, I'm going to tell you, I don't even know why we don't just call Cal OSHA and say, we need to adjust your medication, guys, because that's not the right letter and it's not the right things that need to be pushed out. But the reality is we've got to wake up people to the fact that we're in the middle of a pandemic. During the early stages of our pandemic, we had CDPH visiting us 4 times to check and see if we're following the rules. It's really was a great moment of lack of leadership. COVID 2.0 right now, I can tell you we're building our 50-bed hospital tents right outside of here. And the current trajectory, if that remains, I'm gonna need all 50 beds. These are med-surg beds, but I hope that we're able, this is a picture, thank you, Peter, for sharing with everybody. If you guys wanna come down, I'll walk you through it. We're gonna do a Facebook Live, so you're gonna be able to go to ECRMC Facebook and you'll be able to see it. Thanks, Nicole Wagner, for providing us with the pictures. Also, I wanna remind everybody that the WHO said it best. We used this when I deployed in multiple locations. I'll never forget General Petraeus's question to me is, what does our capability look like, Adolf? I said, sir, our capability in hospitals and health system is space, staff, supplies, and systems. Unfortunately, by the time we were going through that, here I had some bizarre definitions handed to me by city council members and a whole bunch of other things. And I wonder, where were they getting their information from? So don't feel ashamed to actually educate some of those elected leadership. Sometimes you have to actually share with them what we know and not what they know. So patient flow, length of stay, ED boarding, ED surge, throughputs, beds, days of capacity filters, I can go on and on. But right now, the limiting factor is staffing, because everybody wants the same staffing. You have staffing shortages in respiratory therapists in one end. You have ICU staffing shortages for RNs in one end. So where do you go? You have to try to figure out how to make it happen for your system, because if you don't, you'll lose the future. Crisis surge capacity has a definition too, and I think sometimes I'd ask you guys, I know everybody's saying, we're in a new world, right? And everybody's looking for a definition of the new world. I'll tell you what, forget the new world. How about you just stick to basics? In healthcare, we learned that when we go back to basics, basics helps us actually recover the day. So I remind everybody on this call to please go back, rethink your basics of what we used to do to get through the day without computers, without all this stuff, and then think about what is your aim for that day, because you're really gonna get us through the battle. By the way, amidst all of COVID 1.0, we battled the fire. We had our staff had to move 24 patients. I had an entire ward on fire, a real fire. We battled heat at 118-degree temperatures, and it went up to 121. But you know, the fog and friction of life that's happening in the hospitals inside have to be removed by leadership that's steady. And steady leadership, it means getting everybody involved in your leadership team. Don't think that you have the answers yourself. I think you'll lose the war. And remind everybody that we actually were dealing with things like childcare. Childcare became a very big issue for our staff. So having connections with your county office of education like we did, we worked side by side with Imperial County Office of Education to build actually childcare so that our nurses can drop their children and our healthcare workers can actually come to work. Housing, we have housing. You say housing for whom? Well, I have 60 staff members who live in Mexicali who go back and forth. These are nurses and respiratory therapists. And you know, Mexicali at some point, just like Tijuana, were on fire as well for COVID. And I know there was miscalculation, misinformation, and all this stuff. So, you know, help was on its way because we asked the state for help. They send us 2 DMAT teams, or disaster medical assistant teams, to help us. We had the California Department of Public Health, I think, finally woke up and sent us some nurses, but these were newly minted RNs, didn't really know much about anything, and we had to take them, make sure that we placed them appropriately. We needed the help, we needed them, but they were not at the level where we can actually trust them with COVID patients. It was very complicated. We had to appreciate what they know and what we know about the patients. The 3rd team was an EMS strike team to be able to move the patients. We can't thank the hospitals in San Diego and across the state of California for actually helping us out. whether it was me calling Chris in the middle of the night or me talking to Patty at 1 o'clock in the morning to help us get a patient in, everybody stepped in. And I say that because we need the whole team to come in and help. And you guys all did a phenomenal job. A field medical system, I just want to share with you that the FMS at the beginning of it, and by the way, I deployed with field medical systems when I was in the Air Force, know all about them. The access centers at the beginning were not there at the level that we needed to take the right patients. And we struggled with informing the state of that. But I want to thank Dr. Dave Duncan at the EMS system for really stepping up and helping us get through the day. I think now the field medical system as an alternate care site is open again for the second time with about 18 patients, but they're running out of space and they're running out of capacity. The All Access Transfer Center at the beginning was an absolute nightmare and a disaster. And we shouldn't be shy about saying that because we had to communicate that to the EMS authorities. They fixed it. They're fixing it again for the second round. And the Air Force National Guard. I can't thank the Air Force National Guard, my brethren, for coming in and stepping it up. They brought in everybody on the team to try to help us. The California State team really helped us. Dave Duncan, Steve Monday, Kathy Statz, and a whole bunch of other folks. And then finally, I can't forget to thank my own team here for really being brilliant, resilient, tough, dedicated, energetic, and actually pushing forward to get this to the next level. So I want to just maybe share a couple of things. The power of many versus the power of one. I don't want you to fall in the mousetrap of thinking that you've got the answer. Nobody has the answer. Not a single person, with everybody involved, not a single person has the answer. Collectively, the power of engagement of the many minds can help us get through what it was going to take. I also learned to use social media. It was a source of power and stability and comfort for the community. Testimony on the Senate, House, and the floor was needed so that we can get the attention of the public. So you use as much of Zoom as you can. We're Zooming with our staff. I don't care who we Zoom with, as long as you're using it to actually get your message out, get your message out. But we found that using that extra Facebook Live sessions are actually needed by the community. The national stockpile, by the way, I'm sure everybody knows this is an issue of national security, the total numbers and the information in it. But we needed to understand that the national stockpile had a gap in it, had a failure point. And that failure point is we were receiving actually vents that were kind of rusted. They were missing parts. We couldn't use them. The batteries were dead. So we've got to relook, and I hope that in the future, those in powerhouses are going to actually help us with that. When we stood up the command center, we realized immediately, Lou and I, that this is not a race. This is going to be a pace yourself, so you don't actually exhaust yourself, because we had to split days, we had to split weekends, we had to split nights. So rely on your partners to get through the day. I just want to share with you that the culture of the organization, the culture of the community, the culture of the staff, all come to a crossroad during a pandemic. And if you don't understand where you're sitting with that culture, and if you don't understand that there are sometimes goals that are cross path the other way, that it's going to be a nightmare for you to get through the day. Also, the State Department, I'm so thankful that Alex Eastman, Dr. Alex Eastman, that's what Chris was mentioning, came down from the Department of Homeland Security, spent some time down here. Alex and I have known each other since Texas days, and I was happy that he was able to spend some time listening and understanding where we were going. We were getting wrong information about our zip codes and where the patient origin is. And the unknowns for us were two. I'm going to show you a real quick pictures. It's the prison system and it's the skilled nursing homes. At the beginning, were not an issue, but then it became an issue. So the mental wellness and power of your organization also has to be assessed. Nicole Amadon, our Director of Quality, kept the board involved by ensuring quality during a pandemic. We kind of put our arms around what is it that still need to be maintained so that we don't get lost in the mix with additional ICU beds and what have you. We also kept an eye on the Imperial College model that gave us exactly where those bumps were going to be so that our staff knows, hey, that's what we're expecting this week. There's going to be an add-on. So I want to finish up by saying that I'm very proud of the team that we have here. You know, we had to look, listen, and learn. and not get stuck in our own paradigms, because if you do, you're going to actually miss a lot. Also, policy decision, individual actions, and health system factors all come to clash during a pandemic. So I'd encourage all of us to be vocal with our elected officials. 50-state solution is really not a good thing. We need to unify our approach. Patchwork is not a good thing. I want to stop here and thank all of you for allowing us the time to present what we've gone through.
Dr. Edward, thank you. It's clear your passion, purpose, and leadership. Imperial County is very fortunate. The entire Imperial County is fortunate to have you and having a regional center and employees with your leadership. You shared a number of insights, which I'll call pearls of wisdom. I don't think I'll ever see PPE the same way now. I'll always think about politics, pandemics, and economics. You're spot on in so many ways, and many other very rich, hopefully, takeaways that I took. I know many of you have. So thank you for sharing all the great work you're doing in Imperial County. Now, let me move to our final panelist, my good friend in the South, Nerav Jadeja, who is the CEO. He returned back home to Paradise Valley Hospital in May 2019 after spending a year in LA overseeing multiple hospitals. He has served as the CEO and administrator at Paradise Valley from 2011 to 2018, is when I have also worked with him during that time. And during his tenure at Paradise Valley Hospital, something I know he's very proud of is patient safety, and the work that he's done and the accolades that he has received around patient safety, but also his commitment in the surrounding community for his own employees and the surrounding community in National City and throughout South Bay. So we're very fortunate to have another innovative, passionate leader with Nerav. So I'll turn it to you.
All right, thank you, Nick, and appreciate it. I know we've had a lot of great conversations over the last year around COVID, and I appreciate your leadership from the county perspective, because there's been a great collaborative this year that a lot of people don't know about, and it's the county and the hospital working hand in hand. And really, when resources were needed, whether it was PPE, testing, kits, the county, from the County Board of Supervisors to Health and Human Services, to Dr. Wooten and the entire team has been tremendous to work together. And I also want to thank Chris and Adolphe. Our hospitals, all of our hospitals in the county, we used to compete a lot in the past, and it's a healthy competition, and there's a lot of great healthcare, and competition helps to make healthcare better. But in the last year, we're not competing anymore. We're collaborating. We're helping each other. Where there resources that our hospital, we're a 291-bed community hospital in National City, which is just south of downtown. You know, we're working together to make sure that we all have the resources to take care of the patients, because this is truly a pandemic, and we're not going to be successful if we're working individually and not as a team in sharing our resources and our skills and our knowledge base. And I remember early on, it was Chris that reached out to some of the people at the county to facilitate meetings, and we as a group began meeting, you know, at first, you know, socially distant in the same room, but then over Zoom and other formats early in March. And, you know, all of the CEOs collaborated to meet weekly. We were on subcommittees with other county leadership, and that really helped us in the beginning. And Chris shared the spike and you know, what we thought was the first major spike, 1.0 as Adolphe called it. And really it was the collaboration between county, hospital officials, and everyone working together that really kept that from being a larger number early on. And I think as fatigue has set in and people, there is frustration out there, you know, we've started to see more community spread where it was more localized in certain parts of the county. El Centro being one of those first areas in Imperial County. And I remember reaching out to Adolphe and trying to offer whatever support we could. And I remember in 1 week, you know, we took 20 patients from El Centro. And our hospital, we're 291 beds, but 103 of those are behavioral health beds. So that brings us down to about 188 acute care beds. And but we knew that we had staff that went out there that saw what was going on, shared with the entire leadership team what they saw out there. And it was a humanitarian effort to do what we could to help our fellow partners out there that were on the other end of the phone, trying to transfer patients and tears, crying. These people were dying, and there was nothing, there just wasn't the infrastructure in place. And it wasn't anyone's fault or anything. It's just we just weren't prepared as a community, as a society, for this type of an event. We do a lot of disaster preparedness. I think all systems do, but we never think about the entire supply chain shutting down, not just locally, but nationwide, international. And so that really impacted what we saw and how things went. Now, kind of bringing it back to our hospital and some of the experiences that we had. Paradise Valley, for those of you that may not know, is part of Prime Healthcare. Prime Healthcare is a 46 hospital system. 15 of those hospitals are in Southern California. However, we are in about 14 different states. So we have, we're a nationwide company, but locally there's only 2 hospitals in the San Diego market. So oftentimes, with all the great healthcare here in San Diego, we're one of the smaller players locally. And so, we had to work very, very closely from a leadership team locally, as well as with our corporate teams. But we had to look at things from a daily perspective. And I know everybody has talked about safety huddles, but I wanted to take a couple of minutes and just talk about how our daily routines changed overnight. Our priorities shifted. I remember within 2 days, we were talking about doing patient rounding and patient experience, and those are still very important. We still find ways to do it, but we had to stop doing the daily routines that we were used to, and meeting with people and shaking hands and hugs and everything that we're used to now, what are we doing for this pandemic? Everything is shut down, limiting visitation, having safety meetings, not once a day, but twice a day. And that's 7 days a week. And I think all of us, Chris, Adolphe, Nick, we were all working 7 days a week, still are working 7 days a week. But at that time, having those repetitive phone calls saying, do we have our basic supplies? Do we have PPE? Do we have enough staff? What concerns are out there? Because staff are bringing concerns, and we want to be able to communicate, and we're not able to do forums to be able to communicate at this point. So how are we ensuring that we're getting out there and we're updating everybody? In the early days of this, data was good and bad. We weren't sure exactly how this disease was being spread. Was it airborne? Was it contact? Would isolation rooms work? And so, we were taking whatever piece of information we got, in the 8 to 10 hours between our meetings and trying to adjust on the fly. And it was really amazing to see the entire leadership team come together. I mean, leaders from every nursing unit, lab, pharmacy, EVS, supply chain, HR, finance, folks that aren't involved in some of the day-to-day things, asking, what more can I do? How else can I help to help? Physicians. We had physicians that made donations, received donations to the hospital, and when supplies were short, and participating in our daily safety calls and seeing what else that they could do, and coming together as a team. As a hospital, we had to cancel all of our elective volume. As a region, we canceled all elective cases. And that really had a significant impact to all of the hospitals, and not just to the hospitals, but to the patients that were out there that needed some of this urgent surgeries, but were deemed elective and couldn't get those surgeries. So what were we doing to try to get those cases done, because we had to reserve all the PPE that we had. And so, there was a lot of work that has gone in from the hospital perspective, just to make sure that we were trying to stay, one step ahead of what was going on in the community. And we did some interesting things. We got HEPA filters all over the hospital to make sure the air was as clean as possible for our staff. We reverse airflowed most of our patient care rooms to where they're now pushing air to the outside, and that was really unique. One of our physicians brought the opportunity to do intubation boxes, and we created our own facilities team, created several different sizes of intubation boxes to try to make it a little bit safer for our physicians and our teams to intubate the patients that needed intubation. And so it was really, really heroic, and there are so many heroes out there that we weren't able to recognize, or don't go recognized in this, but it was a true collaborative from local levels to the county to the hospitals that really, really did a tremendous job in keeping our counties as safe as possible. And now we're facing new challenges, and I think staffing is something that I know both Adolphe and Chris talked about. But what's really happened is we've seen a number of nurses that were approaching retirement age take early retirement or go out into retirement. We've seen nursing schools pause on their ability to graduate students because they couldn't get into the hospitals to get all of their training done. And so now the nursing schools aren't putting out as many students, and we've had a number of nurses retire, and it's creating a bit of a vacuum in the number of staff available to be able to take care of the patients. We're also seeing other healthcare jobs such as CNA, security guards, environmental services, dietary, folks that are scared, and they don't know what the pandemic is going to entail. But the one thing they do know is that they can do those same services, but not in the hospital. And so we're seeing folks try to find jobs, and especially jobs that are maybe can go across different industries, try to find them in different industries and move there, just because they have fear of what's going on in the pandemic and what they hear out there. So I think there are challenges that we're going to be facing this winter that I know my colleagues are also extremely concerned about, and we're trying to find collaboratives on what we can do, from team nursing to international. I think our facility is looking to bring in 15 to 20 international nurses in January, and we're trying to work through getting the visas and everything completed, because we're going to face shortages. I mean, we're seeing the Halloween and Election Day impacts right now as far as the increase in volumes. We haven't seen Thanksgiving and Christmas and New Year's and everything else that people are going to get together for. So it's going to be, there's going to be concerns. And I think for the first time, we're seeing businesses not ready to comply with some of the concerns out there in the county. And, when this happened in April and March, April and May, I think everybody was extremely fearful, and they were complying. And I think as time has gone and the fatigue has set in, we've seen the compliance start to decrease. So, those are concerns that we're going to see here in the next few months, in addition to the vaccine and the multiple vaccines that will be available, and the distribution of those, and the different teams and everything going into how we distribute them and who gets them, and making sure that they get them, if it's a 2-dose vaccine, that they get them timely on the 7th day or on the 21st day, or whatever the vaccine timeframes are. So I think there's some real challenges ahead, and kind of taking it back to those people that have been impacted by COVID. We hear about the deaths quite a bit. We hear about all of the different folks that have gotten sick, and the total numbers of positive and the total deaths. But I don't think we hear a lot about the other impact that this is having on people and their families. And I know personal stories here of people I know, either at my hospital or at my sister hospitals, where employees or patients have had amputations. They're having neurocognitive issues, other respiratory issues that aren't just lasting 10 days or 14 days, but 6 weeks, 8 weeks, amputations lifetime. I mean, there are other concerns with this pandemic that we're going to be facing, and mental health, and we are a very large player in the mental health community here in San Diego County. There's going to be significant concerns once we're past this pandemic. You know, if it's the end of next year, end of 2021, when we get past the fear and have the vaccinations and everything out, I think there's a new world of problems from people that have been either dealing with mental health issues, suffering from mental health or abuse, that we're going to be dealing with in 2022 and 2023 moving forward. So, you know, while we're also looking at issues and you know, CEOs, we look at what's in front of us today, but also what we're seeing on the horizon. I think our systems are all collaborating and working together, but you know, we're a long ways from dealing with all of the future impact that this disease is going to have. And I'm hopeful that this is a once in a century type event, and that we don't have to go through it again, having worked both on for-profit, not-for-profit, academic, healthcare community, private, public hospitals, seeing all the different sizes. We're all trying to get through this together, and I think all my colleagues will agree that we hope this is the last time that we have to deal with this in our lifetime, and hopefully in our children's lifetime as well. I want to save time because I know wanted to save time for some questions and everything, but you know, from a hospital perspective, you know, we have been sequestered, and our lives have been actually more challenging today than they were prior to this, and they were challenging then. So for those of you that are early careerists in healthcare, if you have a passion for it, stay in this, because there's going to be long-term effects that we're all going to face in the future. Next.
Thank you, Nirav. And thank you, and we appreciate your leadership, what you've done, not only for Paradise Valley, but like your colleagues on this panel with Chris and Dr. Edward, you were one of the most impacted hospitals being in the southern part, Scripps Chula Vista, Paradise Valley, Centro, and our friends at Sharp, obviously, Sharp Chula Vista. The greatest numbers and impacts we're seeing. And we were extraordinarily fortunate having your leadership to be able to manage that. I could not even imagine where we'd be if we didn't have leaders like you, who just did try to do the right thing, do it right, but really cared about what we were doing. And you said it, what makes San Diego shine, and I'll say this, and it's true, and many of us who've traveled seen this, to move from a competitive marketplace to a collaborative mindset, I call that co-opetition. It is very difficult to manage in competitive marketplace and collaborate when we need to. Yet that is exactly what has been exhibited here. And we're all better for it as a result of that. So all three of you have been fantastic in what you've been shared and willing to share, and I appreciate that. I want to move to the questions. And we have already one, and I personally, selfishly have so many questions of you, but I actually, and I'll set one up, but I'm going to pivot to Peter in a second to give the question. Amanda had a question, I believe. I want to make sure our great listeners and people paying attention, give them the opportunity. But just about 10 days ago, we had a hospital CEO county leadership call. This is what's been alluded to by a number of you. All three of you participated. And what struck me was the conversation about what insights you had. And I'm hoping you could share that and we can get to this question. And that is, what's changed from what we saw in the early days of what we were dealing with, the type of patients and the management of those patients, to what we're seeing now? Because I don't think people quite understand there is a difference. And the demands and rigors that has caused for your employees, our hospital nurses and doctors, and the challenges of that. So I'm hoping we'll come to that. But Peter, I'm going to turn to you. I think we had a question in the chat. So can you read that out for us?
Yes, first question is from Amanda. Can you share how you are addressing personal responsibility with your teams related to how they handle themselves outside of work to reduce the spread?
I can take the kind of the first stab at that. I know, you know, we've been very early on. We really took it. We're in the South Bay part of San Diego, and it's very important because we do have a lot of people that live on both sides of the border and work and commute here in San Diego. And we had certain restrictions that were in place here at the hospital. And we expected our employees to let us know if they've been around anybody that, you know, that tested positive, and that they were adhering to the same guidelines, you know, wherever they were. And in Tijuana at the time, you know, the restrictions were not the same. And so there were people that were going, you know, across the border and trying to go to nail salons and other things. And you know, we restricted their ability to work because we wanted to be very careful. Now, as we've gotten more education over time and you know, we know what's allowed, you know, we have a very strict masking policy. You know, if there's more than one person in the room, everybody needs to be masked. And if you leave your office, you need to be masked. So I think, you know, we're trying to practice the same habits that we want all of our staff to do. And what we do is regular communication updates on what the expectations are, and we've had good staff compliance. I think a lot of the people that work in healthcare do it because they want to make it better, and we see that with our staff as well.
The only thing I would add is that we've a lot of education, a lot of communication. I mean, we do not control our people's lives when they're not here at work, and obviously we have strict protocols at work. They have to be, you know, everybody's supposed to be screened by their supervisor every day. And obviously we don't want people coming to work sick, and we have strict masking. We got plexiglass everywhere. I mean, it's, you know, we've done everything we possibly can to make it safe in this environment. But it does seem to me that more people let their guard down. They get together, not just with their immediate pod, but they want to see extended family members, which is, I understand it's been a long time. And I think that's where the risk is. So we spend a lot of time trying to educate, communicate, you know, and, you know, encourage people to follow the appropriate behaviors. At one point, we even bought everybody 3-ply cloth masks just to remind them that they could wear those, not at work so much, but they could certainly wear them at home and around the community. So, but unfortunately, people will act the way they're going to act. And so we are, these days, we're even more careful when people are coming back to work. So for example, after the holidays, we have very strict, if people have been on an airplane or something like that, and they're not an essential worker, they have to quarantine at home. We're encouraging even more telecommuting right now as a result of fear that people may have gotten involved with other family members or friends or things like that, and then upping our screening at the hospital level. But we know people did, you know, pumpkin carving together without masks, and we ended up with an outbreak. And so sometimes it's just behavior. I scratch my head wondering about it, but sometimes there's behavior that people just don't do that's not logical these days anyway.
The only thing I would add is model the behavior you want to see. I don't know how many times I swung by the local burgers and beer joint, wanted to belly up to the buffet and get a burger and a drink. But I said, if people see me doing this, they're not going to believe in the message that I have by telling them to stay at home. So model that behavior to your staff.
Dr. Edward, I can't wait to get a beer and a burger with you post-COVID. Sounds good. We have another question. I'll read this one, Peter. I got this from Barbara Gerber. It seems like contact tracing has not been extremely successful in helping to stop the spread of the virus. Maybe it really cannot be successful in a pandemic. Having taken one course in epi in grad school, I understand what it's supposed to do, but has it helped? And then part two is, in terms of generating community fear and anxiety, is it helpful to report case numbers each day when those numbers may not relate to the actual case day. Let me respond. I'm happy to have Chris and others join in on this. As it relates to contact tracing, disease investigation, contact tracing, in San Diego, we're seeing a phenomenon of about 1.2, 1.4. So for every case individual that's infected, there's a 1.2 to 1.4 multiplier of contacts. It's far better, by the way, than what we're seeing in other parts in LA. That's like 2 to 3, or New York City was even higher, based on density and a number of factors, right? Here's what we do know, is that this is about prevention. If you don't do prevention, yeah, you'll see the impact. If you do prevention, it's having a benefit. So the ability, as I talk about, to pounce on the virus, to immediately to do, and this is why it's all together the T3. Not only do you have to do timely testing at the right time, and it's only a point in time we know when you get that PCR test, but the turnaround. The hospitals do a phenomenal job, about a day and a half. We've gotten sometimes down to a day. County labs, same way. Our partners with Helix. And that's quick, because the quicker we can get that result, we give it to the disease investigator. Here's the thing. We probably can't measure how many people we have helped from getting infected because they got into close contact and we told them to self-isolate. But could you imagine for a moment if we didn't do that? I could tell you for sure we'd have a lot more numbers of people, because we've had about 11% of our cases in San Diego are asymptomatic. Got tested, had no symptoms. We contact them like, Josh, I didn't even know where I got it from. They had no symptoms. So getting in touch with those people that didn't even know that the person had symptoms, to be able, hopefully, do the right thing to protect themselves, their families, and the community, that is an invaluable tool, and something that I think we continue to do. LA did stop doing their contact tracing. They were overrun, absolutely, from the beginning to there now. Not in San Diego. Now our numbers have dipped because the timeliness, when you have an onslaught of cases, you just can't do them all. So we are down to about 70% of timely investigations. We're up to 95%, but we continue to work and do the best we can. That's where it comes down to. In terms of the issue about fear, you know, this is a tough one. We talk a lot about this with our hospital CEOs. Look, data is truth and transparency is important. And it's not there to create fear, but if you can't see the data, it's hard to manage that. And I think this speaks to, you know, reporting at daily, et cetera. It's an invaluable tool for us in public health to know where we're going. It's what Dr. Edward talked about. You got to get there before it reaches that trend. And so we look at data not to create fear, but we look at data to be transparent, to tell the public of what is happening. And you have to be transparent during these times, but also to be able to help us with planning. I'll turn it to Chris and the panel, weigh in on any of that.
Yeah, I'll just say I want to compliment Dr. Eric McDonald, who has been a phenomenal aid to all of us, because I'm not going to comment so much on the community tracking, because that's something clearly that Nick and others did. I wish we could have started it earlier. I wish the entire country could have started it earlier before we ended up having community spread. But at least what we've done, I do believe, has saved lives. But what we've done on the hospital side, when we had an outbreak, we did our own contact tracing, assisted by the county. And I absolutely believe that that helped us contain possible spreads even within our own hospitals. And I think that's been phenomenally important and successful. And again, I want to highlight and compliment Dr. Eric McDonald. He's been terrific to work with, as really all the folks at the county have been when we needed their help and their advice and their expertise.
No, and I think echoing what Chris was saying there, when we have staff that test positive and they didn't get it from the hospital because a family member or someone else had it, going back to take a look at what patients did they take care of, what units were they on, and going back and doing the contact tracing helps us to isolate those. So, you know, I think the question says extremely successful. You know, if there was anything extremely successful, I think we would all be, you know, doing it. But I think this has been successful in at least limiting the exposure to any more people, because any one or two additional patients that get it, you don't know how many more people that they'll end up spreading it to. So I think from our perspective, you know, we do contact tracing in the facility, and it is helpful. and having the data has been helpful to get projections and see, are we increasing, are we decreasing, where are the peaks, and what can we do? And we used a lot of data, not just locally, but from other places like Italy that was ahead of us early on to try to forecast and see what was going to happen and how are we going to be impacted by that. So, I think everything in context has had significant value for us.
I just want to add to the issue of why be transparent, as Nick was talking about. We've learned that in disasters, the Tylenol scare, and a whole bunch of other crises that healthcare has faced, if you don't go out ahead of it and actually explain your story and leave vacuum, somebody else is going to fill in, and it might be filled in with garbage, which you will find a lot on Facebook, and lost stories. So it's best actually to be transparent. And that's why early during the first COVID wave, I did a lot of face-to-face encounters on Facebook Live with our community, because it's so small here, much smaller than San Diego. And if somebody sees me doing something wrong, it'll be on the front page of the local paper. So I think it's best if you're out ahead of it.
Thank you, Dr. Edward. And I know we have more questions. We're going to get to this question. I'm going to take the liberty because it's actually a great question by Andrew, and I think we're going to probably end on this question. I wish we got to more time, but you've been phenomenal as a panel. We're going to end on this one because I'm going to then turn it to Craig Thompson to wrap up. And the question by Andrew is, can you share something that you say to yourself to set yourself for the difficult day ahead? Can you share something that you say to yourself to set yourself for the difficult day ahead?
Andrew,
great question. Can I start with you, Dr. Edward?
Yes, sir. Absolutely. Andrew, thank you for asking. It's a brilliant question. Here's what I tell myself in the morning. 3 things. Integrity first, service before self, excellence in all we do, because that is our commitment to our community, and that's where we need to go.
This is Nirav. For me, healthcare is a very personal thing. I do this because I enjoy what I do every single day. I got into healthcare because as a child, I saw healthcare not working, and it impacted my mom, and it was a very personal thing. So for me, I do this because I enjoy what I do every single day, and so trying to make it better every single day is just my personal challenge and why I do it, and that's what motivates me and brings me into the office every single day.
This is an easy one for me because I think almost everybody at Scripps knows one of the things I do every single day is ask myself a very simple question. Would Mother Mary Michael Cummings and Ellen Browning Scripps be proud of what I did today? And it's, we are not only taking care of this community, but all of us in leadership are extending the legacy of our organizations. And in our case, we were founded by those 2 women who gave of themselves, either their resources or their time and energy. And I think in many ways, that's what we're doing every single day as we come to work and try to work through this pandemic. And so if I prepare myself thinking that way in the morning, and I do ask myself that question when I get in the car at night, it's almost always a resounding yes. I think they would be proud of what we did today. I think that was a good day.
Thank you, all of you. I mean, it's, as you all talking and reflecting, and it struck for me all of the above, and I'll just add mine, and that it's not the start of the day, it's the end of the day, and it's the prayer for the new day to come. And I do pray for my family first, but my family is my work family, and you all are part of my work family. You think about these 3 leaders and the panelists we've just heard, from Chris to Dr. Edward to Nirav, it's more than a job, right? We talk about their deep sense of purpose and passion, right, in partnership for public good. And in a time when we need to save lives, having leaders with those type of principles that sets the tone with their leadership and management teams is probably the driving force for those on the front lines, our nurses and doctors and therapists and social workers and administrative staff and security and all the other folks that make the food service and all the others that make the organizations continue, knowing that our families are in hospitals and in clinics and are being safe. And so we, if there was the audience applause capability, this would be a roaring applause right now for all of you three, your employees, your volunteers, for all that you do. So a sincere thanks. I had the best job at being moderator because I just love the being with my good friends and leaders and learning from them. So thank you each for your great insights and what you do. With that, I'm going to turn it over to Craig Thompson from ACHE to wrap it up.
Thank you very much, Nick, and thanks to all our panelists. On behalf of ACHE, I want to thank our chapter leaders who planned today's session, the moderator and panelists, and all of you for your participation. Please complete the course evaluation by visiting your My ACHE page and selecting My Online Learning from the Helpful Links section on the right side of the screen. From there, click on the Access My Courses link, and you will be directed to our learning management system where you can complete the evaluation. In the same location, you will be able to access the recording of this session within 48 hours. Your face-to-face credits will be posted to your My ACHE account approximately 2 weeks following the session in the My Education Credits section. That concludes our session, which is copyrighted in 2020 by the American College of Healthcare Executives, all rights reserved. Thank you all so much for attending and have a great day.